Hello, my name is Dr. Paul Richardson and I'm the Director of Clinical Research at the Jerome Lipper Multiple Myeloma Center, Dana-Farber Cancer Institute in Boston. So it's my pleasure in the context of discussing the management of adult patients on Defibrotide to present to you and discuss from the basis of our pooled analysis of survival by Defibrotide timing of initiation in adults with veno-occlusive disease and sinusoidal obstruction following transplant, data that we presented at this year's ASH meeting in San Diego. The methods for this were a post-hoc pooled analysis of patients on the International Compassionate Use Program as well as the Expanded Access Protocol. VOD SOS was diagnosed by Baltimore or modified Seattle criteria, and basically patients received Defibrotide, the median dose of 25 milligrams per kilo per day for a median of 15 days, with those patients in the treatment IND receiving it for 21 days or more. Very importantly, the objective of this analysis was to investigate the impacting of time from VOD SOS diagnosis to Defibrotide initiation on day plus 100 survival. The patient population was strictly in the adult setting, and 2 analyses were performed examining patients who initiated Defibrotide, either before or after days 1 through 14 post-diagnosis and on a particular day, with specific statistical methods so used. In terms of the demographic and clinical characteristics, they're summarized here. All the patient number was 537, which represents the largest number of its kind to date. The majority of patients were male. The median age was around 41. The most common diagnosis was acute myelogenous leukemia, perhaps not unsurprisingly, and in that regard also the most common form of GVHD prophylaxis was tacrolimus. The median day from transplant to VOD SOS diagnosis was noted to be approximately 24 days. Again, the vast majority of patients were allograft recipients. What was seen in this analysis was that clearly in all adult patients there was evidence of clinical benefit for patients being treated sooner rather than later from their original diagnosis. And these graphics serve to show that for the treatment initiation day, illustrated in the left and on the right in adult patients with multi-organ dysfunction on the right and all adult patients on the left. As can be seen, the same trend is observed in both, but is particularly pronounced in those patients with multi-organ dysfunction. If you look at a specific analysis on specific days, you can see again the same obvious trend that earlier initiation after treatment matters in the adult patients and is particularly important in those patients with multi-organ dysfunction. The safety analysis from this large combined study of the Compassionate Use Program, the treatment IND, shows the CUP analysis to be very consistent with the treatment IND population and with generally well-tolerated profiles seen in terms of any attributable drug toxicity. And in terms of the AEs reported in more than 2% of patients, they're summarized here, but again, very much what one might expect in the transplant population. Conclusion from this is that consistent with studies showing higher efficacy with earlier Defibrotide, the retrospective study of pediatric patients, for example, or the phase 2 trial of adult and pediatric patients, the day plus 100 survival was clearly higher in patients initiating Defibrotide less than 2 days from diagnosis versus more than 3 days. And these results suggest outcomes may be improved with prompt Defibrotide initiation following VOD SOS diagnosis, irrespective of multi-organ dysfunction. Safety profile was highly consistent with what's been seen before. So as we think about management strategies in adult patients, this data tell us convincingly that earlier intervention with Defibrotide from diagnosis is critical, that the safety profile remains very consistent across all studies and is very manageable, and that in terms of future directions, clearly earlier intervention prior to the development of advanced multi-organ failure and or multi-organ dysfunction is essential, and that indeed in terms of future strategies, combining Defibrotide with other approaches may be of importance, and that finally prophylaxis is being already explored in prospective trials in adults looking at the effects of Defibrotide in allogeneic transplant and high-risk autologous transplant in particular. Finally, I would just simply say that there are improved outcomes in specific high-risk groups. For example, those patients exposed to monoclonal antibodies that may carry with them antibody-drug conjugates, and the sirolimus-exposed patients, or, for example, mismatched unrelated allogeneic transplant, and indeed in the context of GVHD prevention as well. So in summary, VOD SOS is a potentially life-threatening complication of transplant. The mortality can be very high in the setting of multi-organ dysfunction. The current management of VOD SOS primarily involves good supportive care. There is an urgent unmet medical need for better treatment strategy for the treatment of prevention of VOD SOS, and Defibrotide is the only approved polydispersed oligonucleotide for the treatment and prevention of VOD and shows the greatest promise to date. I want to thank you very much indeed for kindly listening to this presentation, which I hope has been helpful. Thank you again.